Thank you very much. As Dr. Beardsley said, I am a physician. I'm also an anthropologist and an improvement advisor and a parent, and it is my pleasure to be here to talk to you about lessons on home visiting program implementation from the Home Visiting Collaborative for Improvement and Innovation Network, or the Home Visiting COIN. This project is really about promoting wide-scale adaptation of evidence-based strategies using continuous quality improvement methodologies. It's important to understand the context of it. This is funded by the Department of Health and Human Services and the Maternal and Child Health Bureau through the Education Development Corporation. The current administration put a strong emphasis on evidence-based interventions and bringing those to scale and investing in early childhood as a window of opportunity. So as part of the Affordable Care Act, they dedicated billions of dollars to home visiting. And that money was used to fund three things. The first was expanding state implementation of evidence-based programs. The second was 2 large randomized control trials. And the third was this first National Quality Improvement Collaborative in home visiting. And the rationale for funding a collaborative was that it could enhance the quality of that spread that the states were taking on and provide evidence to justify this investment long before randomized control trial data would be ready. We use a model called the Breakthrough Series Collaborative, which is a method of improvement for the extension and adaptation of existing knowledge that facilitates multiple adjustments to achieve a common goal. So topics that are ripe for improvement have an evidence base that's not always implemented in practice. And the purpose is to close the gap between what we know works, between the evidence that's out there, and what's happening on the ground in practice. Second, to build leaders in quality improvement, so by training frontline teams at home visiting agencies in quality improvement methods. The theory is this will build on sustainability of quality in those programs over the long run. It will also drive faster achievement of results and demonstrate the effectiveness of home visiting in large-scale implementation. Improvement science describes 2 types of knowledge that are necessary for quality improvement efforts. Subject matter knowledge, which is professional knowledge or content-related knowledge that most of us go to school to learn, and then profound knowledge. And profound knowledge was introduced as a concept by Edward Deming, who described 4 components that are essential to understand if we want to create improvement in the systems in which we work. The first of these is appreciation of a system, that the outcomes we achieve are a result of interrelated processes, pieces, and people. The second is a theory of knowledge. How do we know what we know? How do I increase my degree of belief that this particular intervention is leading to an improvement? And how do I convince others to have that same degree of belief? The third is understanding variation. So every measure has variation inherent to it. If I were to ask everyone in this room to take their pulse right now, you wouldn't all have the same number of heartbeats per minute, but that's not meaningful variation. So we need to understand how to differentiate between normal variation and variation that's a signal of a change or a signal of improvement. And then finally, psychology, the human element of creating change. Knowledge for improvement combines this subject matter knowledge with profound knowledge, and the structure we use makes it easy to use the 4 lenses of profound knowledge when applying subject matter knowledge. The structure is depicted in this image. So the Breakthrough Series Collaborative runs for anywhere between 9 and 24 months. It begins on the left-hand side here by selecting a topic, and a topic is one that has good evidence that's not always being applied in practice. The next step is to recruit faculty who develop a framework and changes, and enroll participants. Those participants will participate in 3 learning sessions separated in time by action periods. At the learning sessions, they come together to learn the content of the subject matter knowledge and some quality improvement techniques, and also to share what they've learned in their own sites. And during the action periods, they test ideas and learn in their own experience. An essential part of this model is that when we enroll participants, we always enroll teams based in organizations, and that those teams should be comprised of leadership, frontline workers, and end users. So when this is applied in industry, end users are customers. In healthcare, those end users are patients. In education, end users are students and parents. And in the home visiting collaborative, end users are parents. So the quality improvement teams that are enrolled in the home visiting COIN have on them administrators and leadership, supervisors, home visitors, and parents who are enrolled in the programs. Each team in a learning collaborative learns to test changes and adapt them, collects data on a limited number of measures, and accelerates learning by sharing their experiences. A huge part of what makes this work as a learning community is that the teams commit to shared aims and shared measures. So the home visiting coin has as participants 12 states and tribes, 30 implementing agencies who use 5 different evidence-based models, 36 quality improvement teams, and 3,500 families. The characteristics of the families enrolled in these programs are very similar to the characteristics of the population that this committee is interested in. And the work is structured as 3 parallel learning collaboratives. So every team works on one of the 3 topics on the left of their choice. They work either on maternal depression or developmental surveillance or breastfeeding, and then all of them also work on family engagement. I'm going to spend the rest of this talk using developmental surveillance and screening as the model. In the question and answer period, we can talk about the other topics if you'd like. So after selecting this topic, the faculty came together and identified what the gap is between the evidence and the practice. So the evidence tells us that identifying children with developmental risk early and intervening is a good thing. But in practice, over half of children with developmental concerns aren't caught till school enrollment, and of the 10 to 13% of children with delays, only 2 or 3% receive appropriate services. We begin in quality improvement from the assumption that these gaps exist despite the best efforts and intentions of the people who work in these programs. So in my experience in healthcare, in education, and in home visiting, the people who dedicate their lives to this work care and work hard. So these gaps are the result of systems and processes that are not designed according to the needs. And this is often very dismotivating to the people who work in these fields. From there, the faculty goes on to define what can we do to bridge the gaps. And they begin by defining an aim that everyone commits to. The simple way of looking at our aim for the Developmental Surveillance and Screening Collaborative is that children who need it receive developmental services. But as part of the method, we demand a specific aim, and that's to increase by 25% from baseline the percent of children with a developmental or behavioral concern who's receiving assessment or intervention in a timely manner. And every team who signs up to participate commits to achieving that aim in the time period of the collaboration, which in this case is 18 months. Next, the faculty builds out a key driver diagram, which is a visual representation of our theory of how you get to that aim. The first column has primary drivers, which are what needs to be in place to get to the aim. Systems for surveillance and screening, for referral and follow-up, home visitors who are supported to address development in their target population, and families who are engaged in the promotion of healthy development. The faculty then builds out the detail of how you get there. So on the far right side are specific ideas to test or change concepts. This is a list of interventions that are very specific and all have a strong evidence base. In some learning collaboratives, for example, in medicine, collaboratives to reduce central line infections have 5 interventions that reduce line infections by 85%, and every team that signs up has to do all 5. In social programming, our evidence doesn't tend to be that clear-cut, and the way we've solved that problem is to say that every team has to work to get each of the primary drivers up and working in their context, but they can do it by picking and choosing the interventions that they think will work best in their context. So the subject matter knowledge is structured in that way, taught up front and tested and practiced throughout the collaborative. The profound knowledge is also taught and practiced throughout the remainder of the collaborative. And at the backbone of it is the model for improvement. There are many quality improvement models. This is one of them. They all have shared components. What this model does is it asks the frontline quality improvement teams to ask themselves 3 questions. What are we trying to accomplish? So within that SMART aim, if I want in 18 months to increase the percent of children who are getting screened and appropriately receiving services, what's the first step I want to work on? So I might choose a shorter term aim on something about screening. Then it invites us, what change can we make that will result in an improvement? What ideas do we have that we think will improve our outcomes today? And then it asks us to be disciplined about measurement by saying, how will we know that a change is an improvement? We could just run a test of change and make a kind of an informed judgment about whether it's working or not. But if I really want to convince myself or a member of my team who's not so convinced by this idea, or someone else on the outside that this is a good idea, I should follow a measure. And then we submit this to a very short cycle of testing called a Plan, Do, Study, Act cycle. The best way to understand these cycles is to do one. We don't have time for that today. So we're going to look at an example from a nurse-family partnership site. They had a QI team led by Emily Haynes, who chose to start their first piece of work focusing on the first primary driver for surveillance and screening. And specifically, they recognized that in their own practice, they were screening children, but they hadn't incorporated parent views or concerns being elicited and addressed at every home visit, which our faculty felt very strongly was important context for interpreting results of screens. So they set out to accomplish incorporation of eliciting parent concerns at every visit. They were going to follow the % of home visits where parent concerns were elicited. And their idea was that they were going to add a label to their home visiting forms and say, were parent concerns elicited at this visit, yes or no? Their plan included adding that label and a data collection plan, following this on nurses' summary sheets. And in the do part of the cycle, they put the sticker on, they communicated to staff in various ways that this was the plan, and after they had run it, they came together for the study portion. And what they found was that the nurses really liked this, that they thought it was a useful thing to help guide their work in the visits, but that some nurses were confused about when to use it. And many of them were only using it if the parent brought up a concern about development. They weren't asking it at every visit. And they recommended that rephrasing the question might help. In the act from the first cycle, they decided to rephrase the question and put a new label on the forms, and then clarified that this question is meant to be asked at every single visit. The act from the first cycle becomes the plan for the second cycle. It's exactly the same. And then they did it. So they added the new form with a rephrased question, which was, did you ask the parent about concerns? Yes or no? Yes, I asked. No, I didn't ask. And what they found after they did this simple adjustment was that their numbers went down. But why did their numbers go down? Because when they said they were asking this 90% of the time, they were asking it 90% of the time when parents had already brought up development. And when they asked it in every single visit, what this chart shows is that they were asking it 50% of the time. And since then, they said, now we're confident that our data is correct and we can see where our nurses are getting stuck. And they went on to continue doing these cycles, and they've increased the % of visits that they're asking this in about 75% of visits. Still shy of what the aim is, but they've made progress. What they said they liked is that PDSA cycles, it's okay to fail because this is a learning cycle. It's a learning process. They've created a culture of quality improvement, and it really forces them to evaluate their own processes and look at where they can get better. They found it was challenging to learn how to do these very quickly. They didn't have to wait a month to learn that the nurses weren't understanding this sticker, but it's hard to get this up and running as quickly as possible. And that the communication was challenging to keep this on the front of people's minds. So they created a bulletin board where they share their aims, their measures, and they invite ideas from every member of their team to bring it to the improvement team. That's just one example. I've circled here on our driver diagram all of the places where parents and parenting are involved in the developmental surveillance and screening driver diagram. And all across the collaborative, people are testing ideas with parents. So in Healthy Families Georgia, they're using the Developmental or Behavioral Screening Passport from ACF to communicate results to parents. The Marion Adolescent Program, Parenting Program in Ohio wanted to improve their anticipatory guidance provided to parents, and they invented this half sheet that says after every screening they provided written feedback, my baby can, and let's have fun working on. And they love this. One of the parents said, this helps me communicate the results of the screen to the baby's father, who's not able to be present at the home visits. And the Pinellas Parents as Teachers program is using a protocol for addressing parent concerns, trying to promote daily reading with their participants in a high-risk substance abuse using population of parents. I'm going to do 30 seconds on measures. We have measures for each of the primary drivers. Having shared measures and looking at them monthly is what makes learning across the collaborative possible. So every month, we look at run charts, which is each of these measures over time. Ask me during the question and answer period if you want to know more. And every month, we look at that first slide, which is the collaborative wide averages, and each measure with the collaborative wide average at top and every participating agency's performance with their name and their data over time. The idea is that if I'm a program who's having trouble getting this in place, I can look across the collaborative at somebody who's about the same size and having a lot more success and learn from them. I have a few reflections when I thought about what this committee has been tasked to do. One is that CQI transforms these teams into protagonists by inviting them to do hypothesis testing on the evidence-based interventions in different contexts. Another, and I'm just going to skip to your questions. So the first two questions that you're tasked to do is identifying evidence. And I think that this is a subject matter knowledge set of questions, and this group is going to get that right. The third and the fourth questions about the types and strategies that may work at universal or preventive or targeting specific groups of parents or specific barriers, it still assumes that all of these challenges can be solved in a design phase. And it assumes that we can create evidence and design interventions, and that the challenge is then looking at the parent and saying, okay, the right thing for you is this one, and then I slot it in. And I think of these things somewhat differently. I think the evidence base is essential, but I think that the challenge for these sorts of questions is more about creating a process that both invites the people who know the most about the family circumstances, the families themselves, the frontline workers, to both reflect on this and practice it, and it gives them tools to do so in testing. Now, this does not fly in the face of fidelity of implementation. We have to follow outcomes and measures along the way to ensure that we're getting closer to our aims and not further. But it's a different way of thinking about these questions that I think is relevant from this work. Finally, for the research questions, I want to know how we can learn more from practice, and I'm specifically interested in mixed method studies and N-of-1 trials. And I'd like to know what short-term proxy measures map onto the outcomes that matter the most in parenting. Thank you.